Thank you for first of all, I thank you all for the invite. And my topic for the presentation is small cell lung cancer, conundrum of brain metastasis. As we all know that small cell lung cancer comprises about 20% of all cases of lung cancer, and it usually disseminates early in the course of the disease when compared to non-small cell lung cancer, and it is clinically more aggressive and usually associated with paraneoplastic manifestations, and 10% of the patient may present with brain metastasis at baseline, and 40 to 50% of the patient will develop brain metastasis later course of the disease. When we see the clinical presentation, it can present with a symptomatic or asymptomatic presentation. Sometimes you can get as an incidental detection on the imaging, and brain metastasis usually occur at the watershed areas of the brain, and clinical picture always depends upon the site of the disease. And unlike non-small cell lung cancer, small cell lung cancer brain metastasis usually have multiple metastases at presentation rather than solitary presentations. And if you see the pathophysiology, small cell lung cancer arises from the pulmonary neuroendocrine cells or alveolar type 2 cells, and they usually have a metastasis which can occur early and extensively. And if you see the neuroanatomical localization of the small cell lung cancer brain metastasis from autopsy studies, it was evident that it's usually it is frequent in positive fossa metastasis at autopsy studies. And what is the best imaging modality you are considering? American College of Chest Physician guidelines says that you can consider either CT, contrast CT, or MRI as the mainstay of the for staging small cell lung cancer for brain metastasis. But NCCN recommends MRI over CT for staging brain metastasis. That may be due to the fact that the number of brain metastasis, which is considered as a prognostic factor in small cell lung cancer, and MRI can detect the very small lesions which may be not detected by the CT. And what about the diffusion weighted imaging of the brain? And it has shown that no ADC values are associated with small cell lung cancer with brain metastasis. And what about the role of Ftg Patch? Ftg Patch can only detect 45% of the small cell lung brain metastasis, which is seen over MRI or even CT. So we know that small cell lung cancer is a chemosensitive disease, and localized disease have a 70 to 90% of response rate to first line treatment, and extensive disease usually have 50 to 60% of the response rate. And most of the patients with the extensive disease may relapse after initial chemoimmunotherapy or chemotherapy. So I'll be discussing what are the roles of surgery. Is there any role for surgery? Any role for radiation, chemotherapy, or immunotherapy? So first of all, surgery. Unlike non-small cell lung cancer, small cell lung cancer usually present with the extensive metastasis. So role of surgery is very minimal. And to my knowledge, there are no studies specifically evaluating the role of craniotomy or surgical resection in small cell lung cancer brain metastasis. Next, about radiotherapy. So in the role of radiotherapy, we can discuss in two ways. One is small cell lung cancer without brain metastasis or patient with the brain metastasis. So patient without brain metastasis, and there is always a role for prophylactic cranial radiation, especially for a patient with a limited stage disease. And it has shown that there is a reduction in the incidence of symptomatic brain metastasis, and there is always a prolongation of survival in patient with a limited stage disease who is responding to the initial chemo or chemoimmunotherapy. And unfortunately, PCA for limited stage small cell lung cancer has shown a 62% of cognitive dysfunction. Whereas if you go for brain metastasis in small cell lung cancer, there are two options. One is SBRT or whole brain RT. So something about prophylactic cranial radiation. So some from various clinical trials and meta-analysis, we can find that the PC has reduced the occurrence of symptomatic brain metastasis when compared to observation, and it has led to the long median survival. So in patient with the limited stage disease, after curative chemoradiation, you get a 5.4% of absolute survival benefit at 3 years. Whereas if you see the role of PCA in extensive stage small cell lung cancer, we have conflicting data, one from the ERTC trial, another from the Japanese trial. So ERTC trial had shown a survival benefit, whereas the Japanese trial did not show any survival benefit. In ERTC trial, patients were not screened for any brain metastasis before PCI, whereas the Japanese trial, there was a screening with MRI before going for the PCI. So there are ongoing research and debate on the role of PCI in extensive small cell lung cancer. So there are debates whether what is the role of PCI in patient with extensive stage lung cancer in the era of chemotherapy. Then there is always a cognitive dysfunction factor, and so there should be hippocampal avoidance of PCI. And next is, what about the role of MRI brain surveillance alone, or MRI brain with MRI brain with PCI, which is answered by the MAVEC trial. And what is the role of stereotactic radiosurgery versus whole brain radiation in extensive stage small cell lung cancer? And it has been shown that in studies, the MRI brain surveillance is a reasonable option in patient with extensive stage disease who responded to the chemotherapy, especially in patient. We can avoid a PCI in patient elderly age. So this is FIRE SLC cohort study, which compared the first line radiosurgery and whole brain RT. And this came in JAMA 2020, where they showed that the overall survival of patients with extensive small cell lung cancer brain metastasis treated with SRS were compared to the whole brain RT. When whole brain RT was added to SRS, it has improved the local improval. There was an improvement in the local survival, whereas there was no improvement in the overall survival. And adding whole brain RT has shown worse cognitive outcomes. Then what is the role of systemic treatment in patients with a small cell lung cancer with a brain metastasis? And right from 1989 to 2010, we have a lot of clinical studies which shown a combination of chemotherapy plus radiation or chemotherapy alone in patients with a small cell lung cancer with a brain metastasis. They use topoisomerase inhibitors, platinum agents, mineral alkaloids, alkylating agents like even cyclophosphamide, and none of these agents showed any survival outcome in patient with the brain metastasis. Then what is the role of IO in brain metastasis? So if you see the historical perspective of the treatment of small cell lung cancer, from 1985 it was cisplatin plus etoposide the first line of treatment, whereas when we come to 2020, it is chemoimmunotherapy. So small cell lung cancer has a high tumor burden, high tumor mutation burden. So we know that high tumor mutation burden is always associated with the efficacy of immune check inhibitors. So we have two trials, IM Power 133 and the Caspian trial. And IM Power 133 showed that when adding atezolizumab to the chemotherapy has definitely improved the overall survival. And similar, the Caspian trial, which was durvalumab added to the chemotherapy, has also shown improvement in the overall survival. But when we take Caspian study based upon the baseline brain metastasis, it has shown that when durvalumab, if you see the brain metastasis or patient without brain metastasis, when durvalumab was combined with EP, which has shown improved survival versus EP alone, regardless of the presence of the brain metastasis.
Anoop, so only 2 minutes left.
Yeah. So if you see the IM Power 133, they included patients only, 35 patients only. So we cannot give a conclusion that in IM Power 133, adding atezolizumab improved, or is there any improvement in the survival, or no improvement in the survival from this data. So there are study design differentiations. If you see the IM Power 133, the untreated brain metastases were totally excluded, whereas Caspian, it was included. When you see the PCI in the experimental lab, it was allowed in the IM Power 133, but it was at only 10%, whereas it was totally excluded in the Caspian trial. So if you next trial is, which is a Skyscraper 02 trial, that is anti-TIGIT antibody tiragolumab combined with chemoimmunotherapy in patient with untreated extensive stage small cell lung cancer. So when you see the interim analysis of PFS as well as the overall survival, there was no improvement in the survival when tiragolumab was added to the chemoimmunotherapy. If you see the subgroup analysis, overall survival, especially in patients with brain metastasis also, the anti-TIGIT antibody did not show any improvement when combined with chemoimmunotherapy, especially in patients with the brain metastasis. So what we understand from these studies that surgery, there is no definite role of surgery in extensive stage lung cancer with the brain metastasis. And about the radiation, then about the PCI, there is definite role of PCI in the localized disease, whereas in the extensive stage, it's all depends upon the treating physician, whether you can go for PCI. PCI is patient who is responding to chemotherapy or chemoimmunotherapy, and also you can also consider MRI surveillance, especially in patient who are elderly. Then there is about the chemotherapy. Chemotherapy doesn't show any survival benefit, especially in patients with the brain metastasis. And about the immunotherapy also, none of these agents showed any direct impact on the brain metastasis, even though it just showed the chemoimmunotherapy has shown survival benefit, the overall survival benefit, but not in patient with the brain metastasis. So the conundrum of brain metastasis still continues. And so the recommendations are, in patient with the brain metastasis, if the patient is symptomatic, you go for whole brain RT before systemic treatment. Then after that, you can continue systemic treatment. If the patient is asymptomatic, administer chemotherapy or chemoimmunotherapy, then consider whole brain RT. Thank you.